Now let's talk about non-hemolytic, no hemolysis, normocytic anemias. So you have the anemia of chronic disease, in which you have an anemia of chronic disease. In chronic disease, you have inflammation. Inflammation causes increase in interleukin 6. Inflammation leads to stimulation of acute phase reactants. For example, your CRP levels, for example, your hepcidin levels. So hepcidin increases. Hepcidin. Remember, don't confuse two things here. We are looking at hepcidin, and here we had heptoglobin. Let me mark that if I see that. Where is the heptoglobin? Heptoglobin. That is different than hepcidin. Hepcidin, if you want to know more, please look in the iron deficiency anemia. I've explained that. So increase in hepcidin, it is released by liver binds ferroportinon. Guess what? Intestinal mucosa and macrophages. That's why it inhibits the iron transport. When you inhibit the iron transport, there's decreased release of iron from macrophages and decreased absorption from the gut. That is all due to increase in hepcidin. It is associated with conditions such as chronic infections, neoplastic disorders, CKD, autoimmune diseases like SLE, rheumatoid arthritis. What is the finding? You have decrease in iron, you have decrease in TIBC, and increase in ferritin. Why you have increase in ferritin? Because the stores are already there. You're just inhibiting the stores to be present within where? Your enterocytes in the duodenum and also your macrophages. The stores are there, but you cannot use them. So you have a low iron and low TIBC. Why low TIBC? Because ferritin is high. That's why low TIBC. Normocytic, but can become microcytic. Treatment is address the underlying cause of inflammation. Judicious use of blood transfusion. Consider erythropoiesis. Okay, an EPO. Erythropoiesis stimulating agent like EPO. Example in the chronic kidney disease. Okay, so that's all with the all anemia of chronic disease. All you gotta know is acute phase reactant, increase in hepcidin, which is going to inhibit absorption from the gut as well as from the macrophages, leads to a lot of stores but nothing in blood. Treatment, treat the underlying cause. If that cannot be treated, and that is like neoplastic disorders, then give EPO. Now let's talk about the other one, which is the aplastic anemia. Aplastic anemia, failure or destruction of hematopoietic stem cell. Hematopoietic stem cells. Causes are radiation will cause that. Viral agents like EBV, HIV, hepatitis virus. Fanconi anemia, which is an autosomal recessive DNA repair defect, which causes bone marrow failure, leading to, we have just learned that a page ago, will lead to pancytopenia. Also, you have the normocytosis or macrocytosis on CBC. So in aplastic anemia, you have normocytosis, normal cells or big cells on CBC. Common associated findings include short stature, cafe aulate spots, thumb radial defects, predisposition to malignancy. It could be idiopathic or due to drugs. Okay, this was all about Fanconi. Again, let me repeat this. We were just talking about Fanconi anemia. Fanconi anemia, it's a DNA repair defect, causes bone marrow failure. When the bone marrow fails, you have short stature, cafe late spots, thumb radial defects predisposed to malignancy. That is because why malignancy? Because you have the DNA repair defect. You can't repair the DNA. Guess what? You're gonna land into malignancy. The other cause is idiopathic. Either immune mediated or primary stem cell defect. It may follow acute hepatitis. And drugs like benzene, chloramphenicol, very important, alkyl agents and metabolites. So something about chloramphenicol. Chloramphenicol is going to give you a dose-dependent thing, but it could be, it can basically lead to both things actually. So what you have is the dose-dependent pancytopenia. You increase the dose, that causes pancytopenia, and it could be reversible, or also it causes irreversible dose-dependent pancytopenia. So it basically causes dose-dependent or dose-independent aplastic anemia. If you have a dose-independent one, you can have an irreversible effect. But if you have a dose-dependent, as you increase the dose, you have pancytopenia, that is reversible. Just stop the drug. But if you give chloramphenicol, it causes it right away. It causes your aplastic anemia. That means it's not dose-dependent. That means it is irreversible, because you cause the destruction of hematopoietic stem cells. Stem cells are out. That means you can't make any cells from the bone marrow. So looking at the findings, we have decrease in retics because of stem. There is no stem cell. How can you make some RBCs? So you have no retics. You have increase in they're trying to compensate it by the body is like, oh wow, where are our RBCs? So they increase the EPOs, erythropoietin levels. Pancytopenia, it is characterized by three things: anemia, leukopenia, thrombocytopenia, versus aplastic crisis, which causes anemia only. You have a normal cell morphology, because you're not talking about morphology here. We're just talking about the stem cell being destruction of the stem cell. And very importantly, they will say hypocellular bone marrow with fatty infiltration. We did a bone marrow biopsy, and it showed, in the bone marrow, we have hypocellular bone marrow with fatty infiltrations, which is look in here. This is all fat. And hypocellular, look at the big cells, but there's not so many. Excuse me. So bone marrow, hypocellular bone marrow with fatty infiltrations, very important. Symptoms is fatigue, malaise, pallor, purpura. Again, fatigue, malaise, pallor due to anemia. Purpura, mucosal bleeding, petechial infection. Oh my bad, petechiae still here. That is due to your thrombocytopenia, decrease in platelets. Infections due to leukopenia. So all three lines are down. All three will give you signs and symptoms according to each one of them. Now the treatment is withdrawal of the offending agent. If there is any agent that is offending, radiation, knock it out. Viral agent, knock it out and do something with it. Either you treat the offending agent, or you just give immunosuppressive regimens. For example, anti-thymocyte-globulin and cyclosporine, or just do a bone marrow allograft, or RBC platelet transfusion, or bone marrow stimulation. So you try to stimulate some cells. Maybe give this. Maybe some cells are active, and all they need is direct stimulation by GM-CSFs, which are the bone marrow cells, progenitor cells. Okay, so that's that's all about the aplastic anemia.